Bismillahirrahmanirrahim. Our lecture today in the second term is in orthopedic surgery is about osteonecrosis and osteochondritis. Now we define the osteonecrosis. It's an avascular necrosis has not been recognized as a complication of the femoral neck fracture. The usual explanation being the traumatic disruption of the blood supply to the femoral head, so that the osteonecrosis is a diminish or deficit in the blood supply to the area lead to this problem. It has been appears as a distinctive features in a number of the non-traumatic disorders like joint infections, Perthes disease, Kaizen disease, Gaucher disease, systemic lupus erythematosus, and high dose of corticosteroid administration and alcohol abuse and as a complication of diabetes and so on. Etiology and pathogenesis of osteonecrosis. Certain sites are peculiarly susceptible to the skin necrosis, including the femoral head, the femoral condyles, the head of the humerus, the capitulum of the humerus, and the proximal part of scaphoid and talus bones. Another factors which need to be taken into account is that the vascular sinusoid, which is nourish the marrow and bone cells, unlike the arterial capillaries, which present in the other tissues. They have no adventitial layer, and their patency is determined by the volume and pressure of surrounding marrow tissues, so that when there is an increase in the intraosseous pressure leading to the osteonecrosis as a material encased in unyielding bones or unyielding component or structures, incompressible structures. So you can see the femoral head and surrounding its blood supply regarding the anatomy, the lateral and medial femoral circumference arteries, and here we have an anastomosis through the capsule and through the metaphysis ligament teres. Here the blood supply to the femoral head. When disruption of this blood vessels in the capsule and the metaphysis, there is diminution in the blood supply to the femoral head, leading to the avascular necrosis of this area. And here the histological pictures or physiological circulation of sinusoidal arterial systems. With the artery here coming, and there is a vein, and this is adipose tissues and bone marrow surrounding this area. If there is an increase in the intracombatant pressure here, it will lead to compress of this sinusoid and diminish of the blood circulation to this area. In this box, we have the conditions, main condition with non-traumatic causes of osteonecrosis, starting by infection like any disease, osteomyelitis, septic arthritis can lead to the osteonecrosis. Hemoglobinopathy like the sickle disease, and you know the sickle crisis in the medicine. Storage disorder like Gaucher disease, we'll discuss it later on. Kaizen disease, dysbaric osteonecrosis, and you know the Kaizen disease that occurs in those diving person under the sea for a long time, where there is dissolve of the nitrogen gases in their blood, and when they return up to the floor outside the sea, they will expose to the low atmospheric pressures, lead to the evaporation of the nitrogen bubbles in the blood vessels, and these causing occlusion of the small vessels here, leading to the osteonecrosis. It was commonly in those using diving in the past century in the Yunnan and in the Gulf, Arabian Gulf, and so on. Coagulation disorders, the familial thrombophilia, hypofibrinolysis, hypolipoproteinemia, and thrombocytopenic purpura. These are bleeding disorders causing avascular necrosis also because of bleeding in this area. Other conditions like Perthes disease, corticosteroid administration, alcohol abuse, systemic lupus, when there is an increased antiphospholipid antibodies leading to the vasculitis and into avascular necrosis. Pregnancy can decrease because of decreased fibrinolysis, and fatty liver also may precipitate avascular necrosis in those pregnant ladies. anaphylactic shock also because of the shock, and thromboembolic phenomena, and ionizing radiation causing also avascular necrosis, direct damage to these blood vessels and affecting the circulations. The bone cells die after about 12 to 48 hours of anoxia. So it has a long time, can tolerate hypoxia. Yet for days or even weeks, the gross appearance of the affected segment remains unaltered because of the framework of the bone structures, because hard structures, so the evidence of the changes not apparent until long times. During this time, the most striking histological changes are seen in the marrow. These are loss of the fat cells outline. First of all, in inflammatory cell infiltrations, like any test segment, there will be infiltration by inflammatory cell into the area as scavenger cells to engulf these debris and remove it from the area. Marrow edema, the appearance of tissue histiocyte, and eventual replacement of the necrotic marrow by undifferentiated mesenchymal tissues, like any reparative process in any injured tissues, because the avascular necrosis is a matter of injury or trauma, like a trauma. However, until very late, the articular cartilage retains its thickness and viability. Why? Because it is dependent on its nourishment on the perfusion and diffusion from the synovial fluid, not from the underlying bone blood supply. So it will remain for a long time, and the final stage, its fragmentation of the necrotic bone leads to progressive deformity and destruction of the joint surface by pressure effect, not by direct effect of the ischemia. The cartilage affected by pressure effect, not by a direct effect of ischemia, because it is dependent in its nourishment on the synovial fluid in the joint, where the nutrient material diffuse on from it by pressure effect. Here, avascular necrosis of the bone, the pathological pictures, you see it, cross sections, and here the changes until finally there is a break of the segment of the bone. Here the edema, you see it, and here the dead segment, hyperemic segment, reactive segment, and this is separated as a dead segment. The changes from nearly normal to destructive segment of the bone due to the ischemic changes. Clinical features of avascular necrosis. The early stage of the bone death is asymptomatic. By time the patient presented with the lesions is usually advanced and the pain is a common complaint, but usually the pain is developed later on because the pathological process it is go for a long time until it is reach the surface of the area where initiate the nerve ending which are present in the capsule and synovium. Okay. It's felt usually in the joint or near the joint, and perhaps only with a certain movement. In resting, there is no resting pain on the start. In the later stage, the joint becomes stiff and deformed, and the local tenderness may be present, and if a superficial bone is affected, there may be some swelling, and movement may be restricted. In advanced cases, there may be fixed deformities, and the process change to a condition like what is osteoarthritis, which was this we discussed it in the last lectures. The X-ray appearance. The early signs of ischemia are confined to the bone marrow and cannot be detected by plain X-ray examination because it is not visualized by the routine X-rays. Subclinical changes. The X-ray changes when they appear seldom before 3 months after the onset of ischemia, and they are due to the reactive new bone formations at the boundaries of the ischemic area, a trabecular failure in the network segment, An area of increased radiographic density appears in the subchondral bone. Soon afterwards, suitable views may show a thin tangential fracture lines just below the articular surface, like what's called crescent sign. This is the fracture, and we mean this is increased density, and this is crescent sign fracture line, and hyperactive area here. And by radiology, this is the evidence of X-ray changes. You can see it. Crescent sign, decreased density, crescent sign, disruption of the joint, and deformed. Then, MRI is the most reliable and sensitive way of diagnosing now for the marrow changes and bone ischemia in early stages, because it will show us the evidence of compartmental changes. A test for the hemodynamic function and the normal resting pressure in the bone marrow is about 10 to 20 mm Hg, rising by about 15 mm after saline injection usually. So we can detect the intraosseous pressure. It is a difficult procedure. So the MRI is then one of the non-invasive and reliable and easy method of diagnosis, especially in certain circumstances when there is patient-sustained trauma with no evidence of early radiological changes. Staging of the lesions. These are pathological changes usually pass through a long time. It takes a month to develop. So we can stage the disease from stage 0 until the advanced stage where the secondary OI changes. These are stage 0 preclinical and pre-radiological diagnostic of vascular necrosis can be suggested only if it has been diagnosed, for example, on the opposite hip joint or early changes on MRI. Stage 1 is the early resorptive phase. On the plain X-ray are normal, but changes become visible on MRI and bone scintigraphy or radioactive isotope studies. Stage 2 is the reparative stage, where the femoral head contour is still normal, but there are early signs of reactive changes in the subchondral bone, what we see in the previous X-ray. Stage 3 is early collapse of the femoral head, and there are clear-cut X-ray signs of osteonecrosis, the evidence of structural damage and distortion of the bone outlines. The frank picture of vascular necrosis, there is a collapse of the femoral head. Collapse of the femoral head, and as you see in the previous views of vascular necrosis, here there is a collapse, and here there is a collapse. Stage 4 shows collapse of articular surface and sign of secondary OI changes. Sign of secondary changes. How we treat the vascular necrosis? Now we discuss its etiology, pathogenesis, and the main general and local factor can causing a vascular necrosis, and how we diagnose and stage the disease, and how we can treat it. Treatment. Early osteonecrosis. Some lesions heal spontaneously and with minimal deformity. This is seen especially in areas which are not heavily loaded, and here one can afford to pursue a watchful waiting policy. Yani waiting and see. This is the policy, waiting and see. We can apply it especially in those bones not susceptible to high load, like the head of humerus. Lesion in heavily loaded joint have a poor prognosis and will probably end in structural failure. Medullary decompression and bone grafting may have a place in a vascular necrosis treatment, such as in stage 1 and stage 2 osteonecrosis of the femoral head. Bone grafting with vascularized graft or avascular graft we will take part of the fibula and insert in the femoral head and neck of the femur. Can be used as decompression and bone grafting. And there is some recent evidence that rates of the femoral head collapse can be reduced through augmentation with mesenchymal stem cells. And the graft is also act as mesenchymal stem cells. Intermediate stage osteonecrosis. Once there is structural damage and distortion of the articular surface, conservative, operative, or inappropriate. The conservative measures are inappropriate. Once the structural damage and collapse occurs, distortion of the surface, there is no way of conservative measures. However, the joint may still be salvageable in certain situations by realignment osteotomy. In the past, we use a lot of surgery, what's called realignment osteotomy in the femoral head, like valgus or varus osteotomy, derotation osteotomy, and so on. Nowadays, it is rarely used because of easiest and availability of the joint replacement surgery. If a mobility can be sacrificed without severe loss of function in the ankle or wrist, arthrodesis will relieve the pain and restore the stability. Sometimes we use derotation osteotomy or arthrodesis in certain joints, especially in the ankle joint and the wrist. Later stage osteonecrosis, non-operative management concentrating on pain control and modification of daily activities and where appropriate supplantage of the joint are done. Arthrodesis of the joint, example the ankle and wrist, or partial or total joint replacement, the preferred option for shoulder, hip, and knee joint. Now, it is the optimum method of treatment. Sickle cell disease, as we mentioned, one of the causes of osteonecrosis, that usually in childhood, the first 2 years of the life may present with a swelling of the hands and feet. The X-ray at the first seem normal, but later there may be suggestive features such as the marrow densities and periosteal newborn formations, dactylitis, and these changes are usually transient. Bacterial osteomyelitis and septic arthritis sometimes involving multiple sites, and there are serious complications, particularly in children, and in over 50% of the cases, the organism is salmonella. So sickle cell disease may be presented with sickle crisis or with sepsis. In combination with sepsis, might be presented and causing avascular necrosis or may be misdiagnosed. Kaizen disease or dysbaric osteonecrosis, under the increased air pressure, the blood and other tissues, especially the fat, become supersaturated with nitrogen. If decompression is too rapid, the gas is released and bubbles, which causes local tissue damage, generalized embolic phenomena, and intracapillary coagulation. And decompression symptoms, pain near the joint, the bend sign was called, a breathing difficulty, and vertigo, the staggers. And only about 10% of the patient with the bone necrosis gives a history of decompression sickness. Decompression sickness. Gaucher disease is a familial metabolic disorder caused by inherent deficiency of lysosomal enzyme glucocerebrosidase. This enzyme important in metabolism of glucocerebrosidase, and the catalysis of this fatty materials interrupted or defected lead to accumulation of this glucocerebrosidase in the lysosomal and reticuloendothelial system to produce Gaucher cells. The effects are seen chiefly in the liver, spleen, and bone marrow. Because accumulation of the Gaucher cells in the bone marrow triggers a series of events that lead to skeletal pathology, of which osteoporosis is the worst one. The blood test reveals anemia, leukopenia, and thrombocytopenia because of defect in the bone marrow. So it is a matter of pancytopenia. A diagnosis, though inconstant, finding is raised of serum acid phosphatase levels. The X-ray reveals Erlenmeyer flask appearance. Erlenmeyer flask, the picture is classic of this laboratory flask given on X-ray. These are patients of sickle cell disease. You see the involvement of the bone, one segment of osteonecrosis on the osteoid bone formation. Sometimes it may be mistaken with infection, the tumor, and so on. And this is a case of Gaucher disease. The X-ray of this scene, the extremities, thin cortices, you should see it, and may lead to pathological fractures here. Here, thin cortices, and the end you see it like a flask, قمع زجاجي, Erlenmeyer flask. You see it, thin cortices, thin glasses like, and this is the shape of the flask appearance of the bone, empty bone of trabeculae, radiolucens bone, and because of this severe osteoporosis, osteoporotic bone, patient sustained a fracture which had been fixed by this nerve. In this case, difficult to treat it because it is enzymatic defect. Now we finished the osteonecrosis and the main condition that causing it, non-traumatic conditions. We come to an important subject, what's called osteochondritis. The term osteochondritis or osteochondritis have for many years been applied to a group of conditions in which there is demarcation and sometimes separation and necrosis. So you can see three conditions: demarcation, separation, and necrosis of a small segment of articular cartilage and bone. This is the definition of osteochondritis. It is a pathological condition characterized by demarcation, separation, and sometimes necrosis of a small fragment of articular cartilage with the bone. Articular cartilage with bone. The disorder occurs mainly in adolescent and young adult, often during the phase of increased physical activities, and it may be initiated by trauma and also by repetitive stress. Now come to first of all what's called crushing type of osteochondritis. It is apparently spontaneous necrosis of ossific nucleus in the long bones epiphysis or one of the wrist or foot bone. Crushing, it is a spontaneous necrosis of an ossified nucleus. Spontaneous necrosis, like the bone necrosis, in an ossific nucleus in one of the long bones epiphysis or one of the wrist or foot bones, like Freiberg disease of the metatarsal bones, Kienbock disease of the carpal bones, Banner disease of the capitellum, Sherman disease of the vertebrae. These are crushing type, loaded bones. Loaded bones. Splitting osteochondritis. What's called osteochondritis, like a piece cut by a sharp object. A small segment of articular cartilage and sub-adjacent bone may be separated, dissected as an avascular fragment. The lateral surface of the medial femoral condyle in the knee joint, the anterior medial surface of the talus in the ankle, the superior medial part of the femoral head, and the humeral capitellum are the common site of the splitting osteochondritis. Spontaneous osteonecrosis of the knee joint, what's called SONC, is similar to the osteochondritis of the medial femoral condyle, but it can be differentiated by its appearance in elderly people, usually women, who are osteoporotic, and the lesion invariably appears on the highest part of the medial femoral condyle. It is a form of osteoporosis, but usually occurs in the elderly, while osteochondritis is a disease of the adolescent and young. This is in comparison, in comparison. Pulling osteochondritis, traction apophysitis, localized pain and increased radiographic density in unfused apophysis may result from tensile stress on the physial junctions, like those in the tibial tuberosity, Osgood-Schlitter disease, and Sever's disease of the calcaneal apophysis, when there is pulling by the tibial patellar tendon or by the tendon-Achilles, hardly pulling on the insertion, leading to the separation and pulling of part of the articular part of the bone and subchondral bone, called pulling osteochondritis or traction apophysitis, like traumatic traction and avulsion part of the bone and articular part of the apophysis. Pulling osteochondritis or apophysitis. Here you see middle part of the talus, the capitulum, the tibial femoral condyle, osteochondritis fragment, here the like an ulcer crater. Remember the barium meal in the stomach, and as a residual we see ulcer crater like this, a cavity with radio opaque part, like an ulcer crater in the duodenum. Part of the bone separated, and there is a radiolucent line, and this is being separated completely, like somebody cut it with a sharp object. Here also appears radiolucent, and the part not so radio opaque. This is present here, not an empty area. These are the main types of osteochondritis. This is radiological pictures of it. Thank you to listen to these lectures.